Hello everyone, and thank you for listening to my talk. My name is Sutton Klein, and I'm a researcher at the University of Sheffield in the Centre for Urgent and Emergency Care Research. When I'm not doing research, I work as a junior doctor in emergency medicine. In this presentation, I'm going to share with you some findings from a study that my colleagues and I have undertaken, in which we sought to explore the role, identity, and experiences of developing clinical competence of advanced clinical practitioners. Advanced Clinical Practitioners, or ACPs as we'll call them from now on, are non-medical health professionals such as nurses, paramedics and pharmacists who have undertaken master's level training and can autonomously assess, diagnose, investigate and treat patients. They work in a variety of healthcare settings, including hospitals, community services and mental health services. They are still considered a relatively new role in the NHS, despite having been introduced in an ad hoc manner since the 1980s. There are many different ACP master's courses available at universities across the UK, some of which are on this slide. And there is also a huge variety of different ACP roles currently available in the NHS. As an example, here are some job adverts for ACPs in emergency departments, paediatric and neonatal services, and even a pulmonary nodule ACP, which is a very specialised role. The wide variety in these training programmes and ACP posts has led to attempts to standardise the role. So in 2017, a definition of advanced clinical practice was posited in the NHS Multi-Professional Framework for Advanced Clinical Practice in England, which described it as a level of practice characterised by a high degree of autonomy and complex decision-making. In 2020, Health Education England began accrediting some of the ACP Masters programmes, which it deemed to have met the standards laid out in its ACP framework. The infrastructure further developed in 2021 for the launch of the Centre for Advancing Practice. This process of defining common standards remains in its early stages, and there remains little research on ACP training programs and their structures or governance. As efforts to standardise and develop the ACP role continue, ACPs are becoming more widespread within the NHS. This proliferation of ACPs brings a need for better understanding of all aspects of ACP training, both during and after qualification. So that's where our study comes in. In response to the uncertainty around ACP training, we sought to explore the training experiences of ACPs with the aim of informing future models of education and support. So my colleagues and I designed an exploratory study of a qualitative design. We recruited a purposive sample of ACPs, both qualified and those with at least 1 year of training, who were working in South Yorkshire and Bassetlaw. But just as our study was about to start, COVID happened, so we held our focus groups virtually on Google Meets. Overall, we ran 5 focus groups, each with 2 to 3 ACPs. The focus groups were transcribed verbatim, and we carried out thematic analysis using grounded theory principles. We ended up rearranging and reorganising our themes multiple times, and to be honest, if it wasn't for publication and conference deadlines, we'd probably still be discussing and rearranging the themes at present. And although this process was a bit frustrating, it's an interesting finding in itself, that the themes are very interwoven with each other and were all interrelated. And that will be important to remember when it comes to thinking about results. So this first theme is structure. ACPs describe 2 major components of their training. There's an academic part, which takes place at the university and consists of different modules, including modules on prescribing and physical examination. And there is a clinical part, which is the clinical training that takes place in the ACP's workplaces, which includes experiencing different clinical settings and practicing patient assessments. The ACPs had generally positive experiences and opinions of the academic part of the training. They described the modules as thought-provoking, helpful and good. One ACP explained, "I found the dissection labs quite alien, but they have really helped to develop my practice." In contrast to the academic environment, the ACPs felt less supported in their clinical setting, mirroring their progress. One ACP described feeling completely unsupported by the trust because they just weren't set up for it. There was no one leading on it. There was no one for us to contact really to talk about stuff. Placements were felt to be an important part of the training and were highly valued by the ACPs, but there were obstacles in organising and undertaking them. Competition with other trainees, the need to beg, and insufficient time on placement were some of the issues raised. For those working in the community or in mental health, placements were extremely challenging to organise, as they needed to take place in a different clinical setting to the one where they worked. One ACP explained, "There's multiple people chasing these placements. There's your physician associates, your ACPs, and your nursing associates now, and then there's medical students. There's just loads of us fighting for these placements." One ACP described finding a placement through begging on a forum on Facebook, while another explained that they were phoning up GP surgeries, practice nurses, stealing, borrowing, begging people, "Can you help me out?" However, not everyone viewed taking the lead on training as a negative. One ACP enjoyed this approach, saying, "I've had free reign over my training and planned everything myself, and that's a positive for me." And where there was a supportive clinical environment, ACPs described their training experience as privileged and phenomenal. Moving on to our next theme, supervision. ACPs described differing experiences of supervision in academic and clinical environments. They described academic supervision as supportive and good, but generally had more negative experiences of their clinical supervision. ACPs were often expected to find their own supervisor, which often proved difficult as a lack of potential supervisors meant that they were in high demand. One ACP explained, "I pinned down one of the GPs to say, 'Please be my supervisor,' while another told us, 'You go to one doctor and they've already committed to being a clinical supervisor for 3 other ACPs, as well as having to fulfill the role of being a supervisor for the medical team.' So it's quite daunting. It's a daunting process having to sort of find that person to be your supervisor." The shortage of training opportunities contributed to tensions between junior doctors and ACPs. The ACPs noted that as permanent members of staff, they were sometimes prioritised for learning opportunities above doctors. While the ACPs generally wanted a doctor to provide medical supervision, they felt that it might be better to be line managed by an ACP who might better understand their experiences and needs. As an ACP described, "I like to be line managed by an ACP who knows what the job is." ACPs indicated that poor, unsuitable, or absent supervision had a serious negative impact on their training and well-being, suggesting that some ACPs had left training because of it. One ACP said, "We're finding we're potentially losing a lot of ACPs due to the lack of supervision we've had during our training." Moving on to our next theme, acquisition of knowledge. When talking about the new knowledge they had learned in the ACP training process, the ACPs noted the differences in the way their knowledge is structured compared to doctors, describing a topsy-turvy process. One ACP said, "I think about cases backwards compared to doctors, as they think about pathology first and then build on that," while another explained, "ACPs are trained bottom up. We learn pattern recognition and then work our way back, whereas doctors know the diseases better." We found that ACPs generally enjoyed gaining knowledge in areas which they had previously found alien. One explained, "What was really good about the training was the in-depth anatomy and physiology that we did," while another ACP described, "The advanced physical assessment and consultation skills course was like walking into Harry Potter world for me with the language and stuff. It was great." Several ACPs identified areas where they felt that they had knowledge gaps, which included understanding blood tests. One said, "One of the frustrations for me is bloods. I don't understand them, I've never done them, and I'm really struggling. I'm frustrated because I want to learn them, and I think something to do with that should be on the ACP course." Other ACPs voiced concerns that they weren't able to consolidate their academic learning into clinical practice, particularly those working in mental health settings. Moving on to our next theme, role identity. The ACPs described confusion and misunderstanding around their role identity among patients, colleagues, and the wider organisation. Many reported that the patients weren't aware of the role. One ACP explained, "I can never go and tell a frail 90-year-old woman that I'm an ACP. She wouldn't have a clue what I was talking about." And there was confusion about the role from different staff groups too, although an ACP noted, "The doctors seem to accept us a little bit easier than the nursing staff." On an organisational level, there was also a lack of understanding of the role, with the ACPs saying that they felt that the organisation didn't understand what they were. One said, "I think the wider organisation have no clue what we do. I think that they probably still just see me as a nurse." The ACPs described the ACP part of their role being tagged on to the end of their previous jobs. This meant that they were often still asked to undertake tasks which were part of their previous roles. One ACP explained, "So we have all of our normal nursing duties with bed managers, triage nurses, we run the hospital, and then you've got ACP tagged on to the end." ACPs themselves were unclear about what their role was, unclear whether they were nurses, medics, or something different from either of these. One ACP summed it up, "We're kind of in that murky in-between water, really. We don't really fit in fully in either camp at the minute." A more positive spin on this blurry role identity was offered from another ACP who said, "I think it is important that people realise that we're not junior doctor substitutes. We have more to offer than that." ACPs pointed to the lack of distinct uniform and unclear pay scales as factors contributing to the confusion around the role identity. These findings are backed up in other studies which have found the role identity of ACPs to be confusing and a source of tension. The final theme for the future was the future role of ACPs. Generally, ACPs had positive experiences of their training and felt that it opened up new horizons to them. One ACP said, "I feel it really boosts your prospects, your opportunities, and your employability." There were, however, mixed views about the possibilities of career progression and future prospects for the ACP role. Some ACPs felt very positive, saying, "There's more opportunities arising all the time as an ACP," whereas others were more pessimistic. One ACP explained, "I honestly don't see where it's going at the moment. I can see potential for it, but I'm skeptical." Many ACPs explained that they wanted to become ACPs because the role allowed career progression while maintaining and developing clinical skills and knowledge, rather than being pushed into a management role. However, once in the ACP role, the opportunities for progression were less clear. One ACP explained, "I don't see much career progression within ACPs other than to become a lead ACP, and there was nothing to define progression within the role from a banding point of view." Some feelings of insecurity regarding the future of the ACP role stemmed from a concern around the lack of understanding of the ACP role within the NHS, and there was a feeling that developments in the role identity and structure of ACP training were needed. Several ACPs talked about the need for accreditation, clear job descriptions, and standardised governance. One ACP explained, "So as an ACP, once you're qualified, you should be able to join a governing body that recognises you as an ACP." And other ACPs talked about the need for Advanced Clinical Practitioner to be a registered, regulated title, which they felt would legitimise the role. They raised concerns about the use of advanced in job titles by a multitude of health professionals that may not have undertaken accredited ACP training. So we think our study raised a lot of interesting issues for discussion, but we've just picked a few to briefly look at in this presentation. So a lot of development of the ACP role in the UK in recent years has been to try and standardise the role. So we've seen the introduction of a new definition, the accreditation of ACP master's programmes, and many previous studies of ACPs have found the lack of standardisation to be an issue. So Katrin Evans's scoping review into ACPs in 2021 noted a lack of clarity among organisations and stakeholders regarding role preparation, role definition, and scope of practice to be a key factor hindering ACP role implementation. While Thompson et al.'s 2019 study on ACPs found a lack of standardisation and consistency with regard to the ACP role. In our study, we found that there were still some calls by ACPs for regulation of the title Advanced Clinical Practitioner and a governing body, but limited calls for the standardisation of master's training programmes. This may be an indication that the attempts at standardising ACPs since 2017 have been coming into effect, or it might be that actually standardisation is not so important to the ACPs themselves. The lack of structure in their training, such as the need for ACPs to beg for placements and supervisors, emerged as a key area that needs to improving as ACP training develops. The issue of confused role identity for ACPs is one that has come up in other studies. Evans noted it to be a source of tension, while Anderson et al.'s ethnographic study of ACPs noted that the confused identity may lead to ACPs being underutilised. The professional identity of doctors is often described to be constructed through a hidden curriculum, which is reinforced by interactions among colleagues and wider society. There are some interesting papers on the different identities that ACPs adopt and the factors that lead to the adoption of these professional identities. So going forward, it will be important for policymakers to not just recognise that cementing a strong professional identity is important, but also making the changes necessary to build up that identity. Thank you so much for listening to this presentation. If you have any questions or comments, please do send us an email and get in touch.